now we go to surgical procedures. And we could spend an equal amount of time on the surgical procedures. So I've asked a Herculean task of Dr. Brinkman to actually cover surgery in 15 minutes. So it's a lot. Dr. William T. Brinkman is a board-certified thoracic surgeon, an active researcher investigator on a number of surgical trials, and has authored more than 30 articles appearing in peer-reviewed journals. So let me turn it over to Dr. Brinkman to talk about surgery.
Well, thank you, Melanie. It's an honor to be here, and yeah, it is a lot to cover in 15 minutes. So we're going to go take a view from 30,000 feet. And I figured since we had so many cardiologists up here, I wanted to bring one of my partners up here too to help protect me. And she just joined us. This is Kelly Hutchison from WashU most recently, and she has a great background in AFib and is an integral part of our team. And I wanted to have her say a few words before I go through these slides rapidly.
Thank you all for the opportunity to speak quickly. Again, my name is Kelly Hutchison, and I just joined Dr. Brinkman's group from Barnes-Jewish Hospital in St. Louis, Missouri, which is where Dr. Damiano is. He's obviously a big name in atrial fibrillation surgical procedures, and his mentor was Dr. Jim Cox, who developed the original Cox-Maze procedure. And then obviously it's been modified over time from the 2 to the 3 to the 4, which all has to do with the lesion sets, which you'll hear about in a minute. And additionally, on a personal note, my life has just recently been affected by AFib in that my aunt 2 weeks ago had a very large stroke from atrial fibrillation and didn't know she had it. And fortunately, she's doing very well, but just speaking to Melanie's point of women commonly being affected, not knowing, my aunt didn't know she had it. She's only 68 years old. She's thin, she's active, she rides horses. She had no idea that she had it, and then had a 80% hemispheric stroke. So it's big, and she's going to do fine, fortunately, and get rehab and get better. But it's important for women as a group to keep it on our radar. And if we think that we're having palpitations or energy is not what it should be, things like that, to go ahead and persist in the possibility that something's actually wrong, as opposed to just powering through it, which is what we tend to do in general, is figure that when in doubt, work harder and things will get better. So I've trained widely in this field with Dr. Damiano, and I'm interested in pursuing the options here in Dallas. So thank you very much for the opportunity to speak, and Dr. Brinkman will fly through all the things we can do.
Okay, here we go. Surgery. So the first thing that we're going to talk about is concomitant maze procedures. You may be having an aortic valve replacement. One lady mentioned she had aortic stenosis. You may be having coronary bypass, or you maybe have another reason. So if you look at these two slides, the percentage of people with coronary disease there on the left, about 7% have atrial fibrillation associated. So you can do a CABG. In the operating room, we can do various things, pulmonary vein isolation, take off the atrial appendage, and we'll go into more details about that, which are very effective. And we can do them rather quickly in the operating room as opposed to 3-4 hours in the cath lab suite. But it is a more invasive procedure. If you have mitral disease or aortic valve disease, much higher percentage have, up to 40% have arrhythmias. So it's much more frequent with valve surgery to have a maze procedure offered to you. Sometimes, they come in for aortic stenosis, and I'll say, yeah, we'll do this maze procedure also, and the patient kind of looks at me confused, and I try to explain to them what the maze procedure is, and that's what we're going to go through. So if you look at the risk of people who have, say, CABG, and you don't treat the AFib, there's evidence that 20% increase in mortality by 10 years. You look at people with aortic valve problems, and you don't treat that, there's worse survival, there's more post-op stroke. Mitral valve, similarly, if you have a mitral valve surgery and they don't address the AFib, There's 18% survival difference at 10 years. And you have increased strokes and things like that. So if you're going for mitral valve surgery or aortic valve, you need to say, hey, a few years ago somebody told me I had AFib, and the surgeon might not be tuned into that at the time because the cardiologist said fix a valve. And that will be a help to you because the surgeon will get tuned in and say, oh yeah, I'll do the maze too. So just remember, this is stuff that the EP guys have been going through, but just remember the electricity spreads from cell to cell, and electricity can't cross a scar. And all these fancy lasers and cryocaths and RF, that is all about creating scar. And we're directing the flow of electricity just as they alluded to before. So some of this is redundant, but sometimes it's good to go over things multiple times. I know I need that many times. So it's just like a maze in the Sunday paper. And we're directing the flow through a maze. It's a simplified diagram, but so it allows to have the normal conduction so the atria can still contract and pump. The atria really function as sort of a priming mechanism for the ventricles. It gives a little extra fluid in there so when the ventricle pumps, your cardiac output goes up. So when you lose your atrial kick, your cardiac output goes down and you feel terrible. So this maintains the atrial kick. So this is a bigger picture, but it's kind of a nice diagram that some of these signals are going off in these blind areas and not causing much trouble. And this is a diagram that Jimmy Cox, Ralph Damiano's mentor, and here we have 3 generations down here, Kelly. But, I mean, we owe a lot to those people, and mainly at Duke and WashU, who started doing these innovative things. And I don't mean to toot my horn. They were mainly surgeons at first, but now the EP guys have taken it over, and that's fine. We're happy to share. So the classic Cox maze is to create scars like we just talked about. You know, we can cut. That's traditionally how Jimmy Cox initially did it. He would put you on a heart-lung machine and cut it and sew it back together, and that's a very definitive scar. Cut and sew maze, which some centers like at WashU, Mayo Clinic, Cleveland Clinic still do a good amount of cut and sew maze, but most people have moved on to these newer devices which make the surgery quicker and maybe a little easier. So, but there is some morbidity associated with the cut and sew maze. You have to have a full sternotomy. You have to go on the heart-lung machine. But in good hands, I think it's a very good procedure, but it's not the kind of procedure you're going to go to early on. It's sort of like we're the end of the line, okay? And we're happy to help you out if you get to that point. Almost all the patients we do our procedures on have had an attempted catheter ablation. So when you look at papers comparing catheter ablation to surgery, it's a little hard to compare the two groups sometimes. So these are what are the things we use? We use bipolar radiofrequency, kind of like what they use with catheters, just a different thing. It's sort of a clamp that we can apply from the outside of the pulmonary veins. And it's very effective at creating a continuous lesion. I think we still have an advantage in that area because with just burning it in spots, you're going to get a few, even with all the high-tech technology they had, you're going to get a few spots where the electricity might get through. You can imagine a situation where the cells are just sort of stunned and not really dead, and they initially do mapping and it looks good, and then later some of those cells wake up a little bit. So we're more definitive in general, but it's real surgery, and so it's usually people who have failed catheter ablations who get offered these techniques, but not always. Then the lasers talked about. High-frequency ultrasound was something that was talked about for a while. We don't think that's quite as effective. We don't use that. In cryoablation, we use that in the operating room also. So most of these energy sources didn't work to our satisfaction. So what works, in our opinion? Scissors, radiofrequency, and cryo, in the operating room at least. So this is don't be scared, about this. This is the inside of the left atrium. They've been showing it to you through a CT scan and MRI, and this is a drawing of it. But this is the mitral valve here. It sits right there. So the guy's fixing your mitral valve, and he can make some lesions here, which create this Cox. Many times we'll do this with radiofrequency around the pulmonary veins and cryo here and here, and you have a very sturdy lesion set. This is a scarier diagram, which is confusing, but it's basically showing you the same thing. I won't belabor that. The other thing we do is, in the original Cox-Maze procedure that was developed, did a biatrial lesion set. We've been focused, the EPs mainly are focused most of the time on the left atrium, and we are too, but we also can offer a right atrial lesion set, which is the other pumping chamber. And it has been shown in many studies to increase the effectiveness of the Maze procedure. So I won't belabor that. I'm actually not going to go through this video right now because I think it's going to take too long. So the Cox-Maze, how effective is it? You look at the Maze 3 series. So we always tell our patients in the first few months, you might have AFib because there's just irritation of the heart muscle, the atrium, from us touching it, clamping it, things like that. But after 3 months, the long-term failure rate is quite low. And in the original Cox series, they talk about 1.2%. I think that's a bit optimistic because of various factors of how closely was this monitored. Like Dr. Risby said, well, 30 seconds, you know. And that's the Heart Rhythm Society definition. If you go, so I don't think Jimmy Cox initially quite met that standard at 1.2%, but it is the gold standard. And I think to expect 85, 90% is reasonable. There is a chance of having a pacemaker, you know, and then the conduction of the squeezing of the atria can be affected for a period of time, as was alluded to in some of the other talks. Now you look at the Cleveland Clinic series, which is also a very good center. They had a 6% pacemaker rate as opposed to 10 to 15, which was before. So there's a chance of that after this surgery. The mortality is quite low. And their freedom from AFib was they were 90% success, and they had no embolic events. So that's a very good series. The Mayo Clinic, they had about a 1% mortality. They had even a lower pacemaker, and 5% failure for the paroxysmal rates. But if they broke out the people with the chronic, the harder to treat, and they had about a 10 to 20% failure rate there. So I'd expect 80 to 90% success. So I'm going to go ahead and go on to what we do that's sort of special with the closed chest Maze procedure. And what we do in that procedure is pulmonary vein isolation, which has been alluded to. We take off the atrial appendage, which is something that, you know, the EP guys are developing very effective techniques for that. But we can apply a clip just under direct vision on the outside and definitively occlude it. And I think there's something to be said for that if you're in the area. And I think that is one of the major ways we decrease stroke risk. We also can ablate some of the autonomic, the ganglion, basically the nerves that lie in the fat cells around the pulmonary veins. There's some people who believe that, as we discussed, ablating the renal veins, ablating other tissue, that decreasing the neural input into the heart can be effective. So that's something else we can offer. So you need to be imaginative in this field. In this field, you know, there's Albert Einstein saying, be imaginative. So we don't use this, to do this, we do not use a sternotomy. It's minimally invasive, but it is surgery. And I tell my patients that. They come in, they're like, oh, it's going to be another ablation. I'm like, no, this is surgery. We're very good at this, but there is a chance of bleeding. You know, we have about a 1% chance of severe bleeding. And if we were to encounter that, we would do a sternotomy to save your life. But it's very rare. We do it with a beating heart. We don't put you on the heart-lung machine. And this is the lesion set we use at the Heart Hospital, and it's one that my partners Mike Mack and Jimmy Edgerton developed. And it's innovative. It allows us to keep the heart beating. And we do the pulmonary veins here. There's a pulmonary vein lesion here, pulmonary vein lesion here. We connect those two across the dome of the atrium. We try to stay low to avoid some of the conduction tissue up here. And then we make a lesion down to the mitral annulus, which is and also a lesion into the appendage. And it approximates what the Cox-Maze, at least in the left atrium. So what are our results? Okay, so if you look at all patients with this lesion set, we had a 75% success rate. And Mark, these are patients predominantly who've had failed catheter ablations before. But if you look at the paroxysmal group, we have a pretty good success rate, all close to 90%. If you look at the persistent and long-term persistent, we're 70 to 62%, which, as Dr. Cowell alluded to, in these difficult groups of patients are reasonable numbers. So where are we going with this? We are moving into techniques of using the strength of the catheter-based procedures and the strength of the surgical procedures in a hybrid OR, doing both at the same time. We're involved with some research in that area. Some of it would be staged, some of it would be at the same time. So what's the rationale for that? The surgeons are good at making lines. The EPs are good at finding bad spots and fixing them. And, the surgeon may fail to penetrate the full thickness if in certain situations, and the EP guy can come back and clean that up. So I think it's a very good approach. So, and the surgeons aren't, to be honest with you, don't have the mapping techniques or the skills with the mapping that many of the EPs do. The advanced, the cafes and all these things, the basket technique, things like that. So I think working together as a team, as we're doing in many areas in medicine, is the way to go, and we're moving in that direction. And I think that's about it. Thanks.